My name is Michelle Nduele, and I'm the Senior Director for Health Promotion with the Arthritis Foundation. It is my pleasure to welcome Christine Stamatos. Christine is a doctor of nursing. She directs the Fibromyalgia Wellness Center in the Division of Rheumatology at Northwell Health. She's also an assistant professor at Hofstra Northwell School of Graduate Nursing and Physician Assistant Studies. She focuses on physical and cognitive behavioral strategies for patients with rheumatic disease and chronic pain. Welcome, Christine.
Hello, thank you, and I'm honored to be here.
So, Christine, let's start our conversation talking about some of the foundational ways you want patients to think about pain in order to be successful in their pain management.
So when I meet with patients, when I teach patients, the very first and most important thing that has to happen is you have to try to identify the underlying reason for the pain. So, if they're coming to you because they have chronic widespread pain and fatigue and they haven't slept for 2 weeks, then that underlying lack of sleep is probably leading to their pain. But if they come to me and they've got huge swollen joints and they can't move and they have stiffness for several hours, well, their pain is coming most likely from an inflammatory arthritis. If someone comes to me and tells me that I just painted my whole house over the weekend and my shoulders are hurting, then I think it's an overuse injury and I have to address it that way. So again, the most important point is that you have to identify the underlying reason for the pain.
That clarification is so important. So let's talk about the role of medications in a comprehensive pain management plan. How do you advise patients?
Most important thing I tell patients is that medications is just part of the equation. The best example that I can give is that medications, I'm going to give Penny Cowan's description of driving a car with your tires flat. So she says people who live with chronic pain, it's like driving your car with your tires flat. And you have to fill all 4 tires to move smoothly through life. And one tire is medications, surgeries, injections, things that someone else can do for you. But if that's the only tire you rely on and you don't focus on the other 3 tires, you will not move smoothly through life. The second tire is physical strength and endurance. So that's the food that you put into your body. That's the sleep that you get, the restorative sleep that you get. That's the weight that you maintain. That's the physical muscle mass you have to protect your joints. So again, if I use the right medications and I eat right and I sleep right and I exercise, but I don't focus on the other 2 tires, I still won't be moving smoothly through life. The third tire is your social value. What are your social connections in this world? Do you have a purpose? Do you feel fulfilled socially? And we are social beings, so that is absolutely critical. And that's where mood comes into play. That's where depression and anxiety and other mood disorders can often affect someone's overall well-being. And what I hear from many of our patients who live with chronic pain is they stop socializing. I never know if I can make it, so I just stop scheduling the events. And so one of my biggest counsels is make sure you do that event, or at least schedule it. You can always cancel at the last minute. The last tire is your self-management techniques. What do you have in your pocket that you can pull out when you're feeling poorly? Do you know how to meditate? Do you know how to change your thinking when your thinking is not working for you? Do you know how to pace yourself? And so again, if you fix 3 tires, but you have no self-management techniques, then you won't move smoothly through life. So I really focus on this when I first meet patients because I tell them there is not one strategy. Medications across the board give us about 20 to 40%, if you're lucky, relief, but you have to do all those other things to manage your pain properly. And I like the car because it shows that it is the person driving the car. It is not the provider who's giving these instructions. It's not the provider who's prescribing things. I can be a coach, basically. I can tell you what should be done, but you yourself have to do it.
I think that car analogy is such a powerful one because it reminds us as patients, I have OA, so it really reminds us as patients how much we are in control as it relates to how we approach pain, how we think about pain, and our kind of capacity to be successful at it. So let's do a little bit of a deep dive and kind of get Christine's top 3. And if it's 5, that's okay too. A couple of categories, things that in your experience as a clinician that you see that work very well for patients, or things that you'd like them to kind of put in the toolbox. So we'll talk about inflammation. I know it's a general category, and I know there's an underlying disease process to inflammation that we recognize. But let's talk a little bit about kind of either inflammation or centralized pain. What are some of the things you think patients should have in their toolbox?
Well, you just brought up two very different issues. You
Okay.
brought up inflammation and centralized pain, two totally different things.
Okay.
So if you don't mind, I'd like to take each separately.
Great.
So inflammation is something that needs to be controlled. Inflammation happens from disease process. It can happen from obesity. People don't realize how much obesity impacts just the inflammatory process. We know that fat cells actually release more inflammatory cytokines, which are chemicals that turn on inflammation, which is why so many of our rheumatic diseases are worse in the setting of obesity. So when patients ask me what they can do, across the board, it's maintain a healthy diet and maintain a healthy weight. And that's something that can be done without any medication. And many patients want to know, well, can I completely control my inflammation with diet? I think actually the Arthritis Foundation does a beautiful job describing nutritional support for patients with rheumatic disease. There is work right now going on. There's something called the ITIS diet. And I believe you can find that on Arthritis Foundation. I send my patients to look that up. It is very hard to study diets because to do a true study, you need to do a randomized control trial, right? So I need to have one person completely be very consistent and absolutely prescriptive for a diet. And then I need the other person not to be. And then I need that to happen over a period of time. And so because that's very difficult to do, studying diet is a really not a clean process. So there are not a lot of randomized controlled trials to tell you this is the diet you should have. But there is mounting evidence that a healthy, well-balanced, plant-based, low-fat diet, you can look at the Mayo Clinic, you can look at this ITIS diet, you can look at the Mediterranean diet. And really, when I touch my patients, I tell them the most important thing is minimize your processed foods, minimize your red meat, minimize your high fatty foods that are your what's that? The fatty acids, I'm blanking on that word, the type of fats that you're not supposed to have. Oh, it's not coming to me. I apologize. But it's just
saturated fats and trans fats.
Thank you. Saturated fats and trans fats. That's exactly what I was thinking of. So you want to minimize those things. If you do all of that and you maintain a healthy diet, a healthy weight, then that's the most you can possibly do for your underlying pathophysiology. Another thing a lot of patients ask me is they come to me and they have markers for rheumatoid arthritis or lupus, but if they don't at this time meet the criteria for one of those diseases. And so they say, well, what can I do to prevent that? And that's when I again focus on the fact that you really need to optimize your diet, optimize your sleep, optimize your physical strength and endurance overall.
Okay. So you mentioned that you want to separate centralized pain from inflammation. So any separate thoughts on centralized pain specifically?
So centralized pain, the belief is that centralized pain occurs when any type of pain is untreated. So when a pain goes on for more than 3 months, it becomes chronic pain. The longer that pain goes on, the longer it changes your processing of pain. And that's what centralized pain is. Centralized pain is your brain starts perceiving things as painful that should not be painful. And there is an actual physiologic process that's happening. More messages go to the brain, and then the brain's ability to blunt those messages to say this isn't painful is not as intact. And then there's an exaggerated response to that pain. So overall, the pain becomes more severe. And it's quite significant when an underlying inflammatory disease isn't recognized, often turns into a centralized pain problem. So now I have two problems. I have that problem of the underlying inflammatory arthritis that needs to be treated, but I now also have centralized pain. And I have to say the spondyloarthropathies are really a significant place where we see that. Another condition, lupus and Sjogren's disease, these are other places because the diagnosis is not always easy and straightforward. It can take anywhere from 2 to 5 to 7, even some epidemiology will tell you up to 12 years to be diagnosed with some of these different conditions. And all that time, there's inflammation going on here. I tell a story in my talk about a woman who has a BMI of 68 who came to me with psoriatic arthritis. But because her BMI was such, nobody looked past her weight and never even saw the fact that she had this recurrent rash on the palms and the plantar surfaces of her feet. And so she went on for years having this inflammatory arthritis and then went on to develop centralized pain. So when I met her, she came to my fibromyalgia clinic because she had widespread pain. Well, the way for me to treat her was recognize that she had this underlying condition, treat that underlying condition, but I also had to treat her centralized pain. So she has a mix of therapies that we're using for her. And if you're interested, I could give you just sort of a quick summary of everything that it took to get her comfortable.
Yes, let's do it.
Okay. All right. So from an inflammatory arthritis perspective, I had to put her on a biologic agent to get the inflammation under control. We used short-term steroids to quickly put the fire out, and then we used the disease-modifying agents to keep the fire out. But that wasn't enough. She still had chronic pain. So I also then had to address her sleep. With a BMI of 68, there's a high suspicion of something called sleep apnea. So I did a sleep study. She, in fact, had severe sleep apnea. We had to get her a CPAP machine, but she still had chronic pain, and she had centralized pain because of this long-term condition that she had that was left untreated. So we ended up also putting her on a drug called gabapentin, which alters that centralized pain response. It basically blocks the messages going to the brain, and then it calms the brain down so it can blunt the pain response a little bit better. The other thing that we did is we had to get her to do some weight loss. She's down now 60 pounds. She's doing exercise. She's doing exercise at home, and she has a strong social network. So she's really doing and she continues to work despite all this pain. She never stopped working. So she's really hit every single one of those tires.
That's what you call a comprehensive plan. So that is a case study and the importance of tackling the sources of pain from so many different angles, because of course they're coming from completely different places and are all compounded working together. That's a great success story. So thank you for sharing that, because it really reinforces the comprehensive approach method. All right, so let's move on to some of your key takeaways, recommendations around sleep.
Yes. So actually, when I talk to my patients, when you have 20 minutes with a patient, and you really have to get something in, the most important thing I can ever say is that if you don't fix sleep, nothing else that you do matters. You have to have sleep. Everyone has to sleep. My takeaway there is that sleep is mandatory. It is not optional. There is a minimum of 6 to 8 hours of sleep. Everyone has a slightly different criteria for how much they need. You need to find the amount of sleep that feels good for you. But we know that if you don't get a minimum of 4 hours of uninterrupted sleep, that your muscles never relax. Well, if your muscles never relax, it's like you're running a marathon every day. Of course, your muscles are going to hurt all over, and muscles are going to spasm. And when they spasm, a muscle spasm is, everyone remembers what a Charlie horse feels like. Well, that's what muscle spasm feels like for people. So when I meet people that have chronic neck pain or chronic lower back pain, it's almost always that their sleep is very disrupted. So you have to figure out how to fix that sleep. So then you have to ask yourself, well, what is the problem with the sleep? Is it trouble falling asleep? Is it trouble staying asleep? Or do you have no trouble falling, no trouble staying, but you wake up and it's non-restorative sleep? And if you answer yes to any one of those questions, then you have to go back and say, okay, well, what is the underlying problem? So if your problem is falling asleep, is it that you're anxious and you can't stop your mind and you worry about the world? So some of the things I tell people, if that's your problem, is I tell you to get a journal and put it right next to your bed and write down all those things that you're worried about. So you've put it out of your head, and now you can try to fall asleep. If it's that you watch TV. So that's the biggest thing that I see, is there's supposed to be no screen time for 30 to 45 minutes before bed. And when I ask, I would say, I really should do this study, but I would guess that 80 to 90% of people look at their screen before bedtime. So, so then I say, you should read a book, do something quiet. And if you read a book on a device, it needs to be in blue light. But think about it. If you're looking at emails, or you're looking at Instagram, or even, you're looking at TikTok, which is making you laugh, every time that you go to another screen, your brain is turned on again, and your brain says, oh, it's not time for sleep. So those simple things make an enormous difference. The other key takeaway that I give patients is that your bed is for sleep and sex and nothing else. Your bed should not be for eating. Your bed should not be for working. And, in these times with the pandemic, many people turn their bed into a multi-purpose room, but
Right.
that's not the case. And also, if you have severe insomnia, the bed can also become a scary place. So the recommendation is if you can't fall asleep, you're not supposed to stay in bed. So if it's 20 to 30 minutes and you still haven't been able to sleep, you're supposed to get up, go to another place, go somewhere quiet. Don't turn on a lot of lights. Don't turn on the TV, and do a quiet task that won't activate your mind, and then try to go back to the bed.
Okay. Very helpful. Thank you so much for that. That I'm going to definitely have some key takeaways for myself as well.
Can I go back to one more example about that?
Of course.
So often what people do is they don't give themselves the time for sleep. So I've met many people and I ask them to bring in their activity trackers and show me their sleep, and they don't go to bed until 2 and then they get up at 5. That is also a problem. So you have to give yourself the time for sleep.
So be more intentional about planning to sleep is as important as the sleep experience itself.
Exactly.
That's where I'm falling down, is that intentionality. So I kind of look up and it's 2 o'clock in the morning. So
yes.
So I really appreciate that for myself. And I'm sure a lot of patients will too as well. They see themselves in that experience. So let's close it out with important topic of mood. And you mentioned the 4 tires before, and social support and all the issues around emotional well-being. So let's get some key takeaways on how to manage mood problems.
So I also want to say that you will not control your pain if you do not control your mood. So my main thesis with my patients is you have to sleep and you have to control your mood. If you don't do those 2 things, you won't control your pain. So mood, again, you have to identify the source of the problem. Is it anxiety? Is it depression? Is it a combination of the 2? Is it reactive, or is there an underlying severe mood disorder? So if it's reactive, you want to find the reason for that and you want to help someone manage it. But really, mood can be managed oftentimes through proper diet, through exercise and sleep. So that's again why I go back to sleep. I can never tell what the underlying true mood issue is if someone isn't sleeping, because lack of sleep increases anxiety and increases depression, affects cognitive ability. So you have to go back to fix the sleep first and then see what's left over for the mood. The other important thing is to do a family history. If there's a strong family history of a mood disorder, then I'm thinking more that I maybe am going to have to also add medication. And so that leads to the next question: when is medication necessary? And what I explain to people is when you can't get out of your own way, when you can't make the changes that you need to make to get well, it's time to, even if it's only temporary, use a medication to help you. And in the field of rheumatic diseases, what I find that we frequently have to use low doses of something like an SSRI, which is a serotonin reuptake inhibitor, because living with a chronic disease there's a loss that's happened there. Your life is not the same as it was before, and that takes an adjustment, and people are not fully well until they've come to accept their new reality. And that's not always easy for people. And while, I sometimes I can't get people to that acceptance level fast enough. If the mood is interfering, it often means that I need to use a medication. Another time that a medication may be necessary is when someone's condition, the stressors in their life, they have no control over. So if someone's in the middle of a divorce and they've just lost a parent and they have a sick child, they can't do anything about a lot of those different changes. So what we can do in that setting sometimes is give them a medication to help them, but at the same time, connect them to the resources where they learn things like meditation and relaxation exercises and cognitive restructuring, so that they can learn to change the way they think about the issues they're dealing with.
Christine, thank you so much for taking the time to talk to us today and for giving so many wonderful insights to our patients.
You're welcome. It was fun.